let us start the open fracture debates. It is debatable, most often asked in the examination, and it is very important for the hospital practices as well. What are the management parts in the A&E, in the emergency room, wound management, antibiotic to be given, tetanus toxoid is to be given, immobilization is to be achieved, analgesics and IV drip is to be given, and ALTS guidelines to be followed in critically injured patients. So, advanced trauma life support system comes into play in critically injured patients. Now, initial management and its controversies. A lot of debatable parameters on initial management are there. Say, for example, the antibiotic treatment, when to start, debridement, when, how urgent it is, and decision of temporarily external fixation, or should we do the definitive fixation. So we'll come to that one by one. Tetanus immunization and prophylaxis. Tetanus is caused by infection from the Clostridium tetani, which is an anaerobic bacterium commonly found in soil, and you have to administer tetanus toxoid if the last booster was given more than 10 years ago, or the history the patient is giving is not viable. The cases where the wound is contaminated with dirt, saliva, or feces, there is always a chance of infection by Clostridium tetani. And in those situations, along with the tetanus toxoid, usually the tetanus immunoglobulin in the dosage of 250 to 500 international unit is to be given. Digital photos are necessary for documentation. Initial appearance of the extremity and can be valuable addition to the medical record. And also the digital imaging allows other members of the treatment team to see the wound preoperatively without repeated manipulation of the wound. And then the wounds must be dressed with a sterile moist gauze, and clinical realignment of the limb can be accomplished with a temporary splint or traction. We must give antibiotics to the patient. The British Orthopedic Association recommends that administering the antibiotics should be done within 3 hours from the injury. The route of administration should be parenteral. Usually nowadays it is considered therapeutic. So administration of antibiotics is best considered therapeutic rather than prophylactic, because there is always a high risk of infection, the absence of antibiotics. Now, what kind of the antibiotics, how to choose? So type 1 and type 2, most of the authors believe that first generation cephalosporin is good enough. Some authors advocate to add gram-negative coverage as well. Say, for example, gentamicin. Type 3, now they are contaminated most often by the gram-negative organisms. So they should be protected against gram-negative organisms, and additional coverage should be given for anaerobic bacteria. Many are of the opinion that we should include penicillin for the risk of Clostridium infection. So local or national protocols are of high value if they are adequate to current evidence and population antibiotic resistance. The British Orthopedic Association suggests the use of coamoxiclav 1.2 gram or cefuroxime 1.5 gram every 8 hours until the wound is debrided. If there is a penicillin allergy to the patient, then choose clindamycin as well. Local adjuncts can be given. Say, for example, the gentamicin beads. So antibiotics placed in the zone of injury can achieve high local concentration of the drug without systemic side effects. And it is given in the beads. That beads is made of polymethyl methacrylate, popularly called bone cement. And many of the publication nowadays suggest a benefit in the use of early vancomycin powder in the wound to prevent biofilm formation. What does it do if you give the antibiotic beads? The use of multiple small beads creates a relatively large surface area for antibiotic release. And it also serves the purpose of a spacer. So antibiotic cement spacers may also be used to prevent soft tissue spaces in the presence of significant bone defect. And during the subsequent procedure, the cement spacer can be removed and the void filled with the bone graft. And there is some interesting research that is telling us that the pseudocapsule that forms around the cement has some osteogenic property as well. So it enhances the bone formation. Ideal duration of the antibiotic. When you start, how long it to be given? So many of the authors, they are of the view that it should be given maximum up to 72 hours. The current evidence supports perioperative antibiotic for 24 hours or until complete wound coverage or closure has been achieved. Now, debridement is a necessary procedure, and what is the principle of the debridement? The propensity to exercise as little as possible should be avoided in open fractures, because if you debride little, there is always a chance of high infection rate, especially in type 3 injuries. So remove any obvious devitalized tissue, including bone, at the initial debridement. If a second debridement is warranted, if you think you have to do the second debridement, some questionable muscle may be left and its fate will be decided in the next debridement, whether to remove or it becomes viable, then not. And ideally, the coverage of the open fracture must take place after one or two debridements. When to do the debridement? Time of the debridement is also under controversy. So there used to be a 6-hour rule open fractures for early debridement, but the recent publications have put this in doubt. There is enough evidence that supports that time for debridement is not a main factor that conditions infection rates or outcomes. This debridement can be safely performed in the first 24 hours, and there is a consensus to wait within this 24-hour period for the best conditions. Ideally, it should be done with the orthoplastic team who are anyway going to do the reconstruction later on. The debridement, which is done in the night, 7 p.m. to 7 a.m., has been found that they carry a significant risk factor for infection. It is inferred that the proper medical optimization and knowledgeable support staff contributes to the improved patient outcomes. And primary early closure of the open fracture will improve the outcome and diminish septic complications. If surgery is to be delayed for a few hours more, in the case of open fractures, the sterile and antiseptic coverage of the wound is a must. That should be done. And a provisional splinting with attention paid to the basic length, rotation, and alignment is usually done. There are scenarios when more emergent debridement may be needed. And these scenarios are type 3 injuries with vascular compromise, or when there is cross fecal or soil contamination. The procedure is one by one, each layer has to be taken care of. So, skin, the edges of the traumatic wound should be trimmed to the healthy bleeding edge. Loose subcutaneous fat, remove it. Muscles which are severely contused or non-contractile must be removed. Bones free of soft tissue attachment should be removed. Only exception to the bone fragments which are loose is the major articular fragments. They should be. So sometimes there may be a role of multiple debridements, especially in high energy trauma cases. So in principle, it is best to avoid infection by removing devitalized bone and muscle, and then to deal with later reconstruction by using bone grafting and soft tissue flaps in an aseptic environment. What about the swab for culture and sensitivity test at the initial stage? The bacterial culture of the open fracture wounds before or shortly after the initial debridement is of little clinical utility. It has been seen that organisms isolated in the acute phase of the treatment do not correlate well with the clinical infections that results later on, and therefore the routine use of the culture at this stage of the care is of little benefit to the patient and is not cost effective. Let us understand about the wound irrigation. Washing the wound with the large volumes of the fluid will definitely remove micro contamination and clotting that may obscure the view of the deeper levels of contamination and damaged tissue. And once the macro contamination is eliminated, the irrigation now serves to diminish the residual bacterial contamination of the remaining healthy tissue. And irrigation is often done in conjunction with the surgical treatment. Low pressure irrigation is usually preferred. Pressure above 50 psi, they usually damage the soft tissue. And if power irrigation is not available, a bulb irrigation is usually available in the operation theaters that can be used. That is, if that gives sufficient pressure for the dirt and the contamination to be removed. Normal saline is the good choice for the irrigation. Should the antibiotics and antiseptics be mixed? The advice is not in its favor. There is no clear-cut evidence that they are having some ultimate result on the infection. The chemical makeup of many of the additives is similar to that of the soap and thus potentially can cause tissue swelling and creation of surface layers over the damaged tissue. How much saline? 3 liters for type 1, 6 liters for type 2, 9 liters for type 3. There is lack of evidence-based recommendations in the literature to guide surgeons on the appropriate additives for the irrigation. So better avoid any additive to the normal saline. What about stabilization? First is why. The stability imparted to the bone helps minimize ongoing trauma to the soft tissues, provides a stable scaffold for tissue healing. It allows for early functional motion of the extremity, and nursing care and mobilizing the patient out of bed are facilitated as well. Stabilization is done in grade 1 in pediatrics patient. Close reduction and POP sometimes is good enough. But for the most of the open fractures in adults, external fixator should be used. Now there is a trend that internal fixation with the interlocking nails can be done in grade 1, grade 2, and grade 3A fractures. Plate and screws, usually the answer is no. Usually, we'll talk about it in upper limb fractures. So, the debate is about the initial fixation method of femur and tibia. It is very important to obtain an adequate fixation to minimize the pain and optimize wound healing and also facilitate patient mobilization. So it seems that grade 1 and 2 open fractures can be managed in a similar way like closed fractures with adequate antibiotic prophylaxis and wound debridement closure. Fixation of the tibial and femoral fractures by a reamed intramedullary nail in grade 1, grade 2, and grade 3 fractures is quite reasonable. What about the management of grade 3B and grade 3C fractures? So first, in the case of grade 3B and grade 3C, the focus should be on the need of amputation versus limb salvage. Can it be salvaged and can it be functional, or it should be amputated? In the case of 3C open fractures, muscular repair is mandatory and the effort should be focused on obtaining a quick and stable fixation to protect the vascular repair. In these cases, we should also consider early preventive osteotomies to prevent compartment syndrome. Now, definitive management is required in the course of the treatment. When to do? So, in the case of polytrauma, patients with high energy trauma, most of the patients are treated with temporary external fixation, and which is proposed that the later on will be replaced with a definitive internal fixation. If you want to do the definitive internal fixation, it is better to perform this conversion in less than 2 weeks' time. Now, unusual conversions of external fixators can be seen. So, fixation in grade 3 open fractures with bone defect. If there is a bone defect, it is difficult to put the internal fixation devices. So, in those situations, the use of external fixation may be useful for definitive treatment as well. New modular devices of the external fixators allow us to achieve adequate fixation with different configurations. In cases where an external fixator has to be kept for a long time, say for example more than 4 weeks, what to do in those situations? In those situations, it is reasonable to retire the external fixator and use an orthosis or a POP cast and wait for further 2 to 4 weeks to look for any septic complications to appear. If nothing is appear, then after further 2 to 4 weeks, perform definitive internal fixation. Now, definitive internal fixation in the upper limb, which one to do? So, in the upper limb, use of plates is more common and gives satisfactory results as well, especially in the humeral open fractures. So, it is safe to perform the conversion of the fixation from external fixators to the plate during first 2 weeks after surgery with, of course, a reasonable complication rate. We have to decide limb salvage or amputation. To salvage or not to salvage, there are few guidelines we can have it. Say, for example, OTA classification for open fractures, mangled extremity severity score is one, and there is one Ganga hospital score as well. Because of the legal reasons, it is important to include the clinical records, graphical documentation of injury, especially in those cases who have decided that it will end in amputation. The amputation or conservation of the limb is to be decided, and when you decide that you are going to conserve the limb, so what are the likely outcomes? Remember, you are going to face a secondary amputation rate 3.9% and a complication rate near 40%, 24% non-union, and 8% long-term osteomyelitis. In case amputation is done, then re-amputation rate is 5.4% and the complication rate is 25%. Very high in both the cases. So actually, at 7 years post-injury, patients treated with amputation or limb salvage procedure were found to have similar poor outcomes. The costs were nonetheless higher for amputee patients because of the cost of the prosthesis. And what are the factors that can modify the final outcome? Most glaring and important is the tobacco consumption. Tobacco consumption is one of the most important, with an increase of 37% of the non-union rate. Increase higher than 2 times in infection, and almost 4 times they have osteomyelitis. So ceasing the smoking will improve union rate, infection rate, and risk of osteomyelitis. But the patients will never have the same risk as non-smoker. The complication, anyway, is non-union and infection. So thank you very much. We have come to an end of our topic. For any query, you can contact me on my mail that I have given it. Thank you very much. Go through the video a few times and be competent to answer all the questions that can be posed to you. Thank you very much.